Welcome to Neonatal Resuscitation. My name is Julie St. Martin and I will be narrating these lessons for you. We're going to go ahead and get started, and what we're going to first start with is fetal circulation. We're going to go over fetal circulation both before delivery and after delivery. So let's get started with what goes on with the baby prior to delivery. So you see here off to the left, we have the placenta. Everything else over here is a diagram of the fetal organs that contribute to fetal circulation. We're going to go over several adaptations that fetuses have in order to perform in utero respirations or circulations in order to keep oxygenated blood coursing through their veins. So we'll get started with the primary source, which is the placenta. So you can see here that this is the mom side over here, and then of course the baby side right here. So there's these little finger-like projections that come out, and the mom's blood pools in this portion of the placenta. So these finger-like projection is where absorption happens. The oxygenated blood from mom's circulation filters through these little finger-like projections into the first adaptation that we'll go over, which is the umbilical vein. So you will notice here there is one umbilical vein and there are two umbilical arteries. So the umbilical vein comes through here. It is oxygenated blood that will travel up the umbilical vein directly into the liver. Now what happens, you see this little dissection in the liver right here, and the blood can go into portal circulation, but there's an adaptation right there where most of the blood filters through, and this is called the ductus venosus. So what happens is most of this oxygenated blood directly from the placenta, from the mom, goes directly into circulation into the inferior vena cava. And if you notice I turned it a little bit of purple is because it's meeting up with some of the unoxygenated blood that is coming up through the inferior vena cava, and it also dissects up here at the top with the unoxygenated blood coming from the superior vena cava. So they mix here and dump into the right atrium. Now the blood in the fetal circulation during in utero life is on average about 60% oxygen. So they do not require as much oxygen as we do extra utero in order to survive. This is an adaptation that the fetus has in order to sustain life in utero. So we'll see this later in the algorithm, because when we're dealing with adults, we are pushing really hard for 95% or greater in oxygen saturation, but we can't push a fetus too quickly because of this. They have been sustaining roughly 60% oxygenation in their blood system, so pushing them up to 95, 99 too quickly can actually cause damage. It can cause hyperoxemia, so we don't push this too quickly, and we'll go over that again in more detail once we get into the algorithms. So again, we have this blood coming in. It's coming from the superior vena cava. It's coming from the ductus venosus, which is meeting up with the blood circulating through from the inferior vena cava, and it's dumping into the right atrium. And as it does with adults, it does drop down into the right ventricle. But the problem is that there is this resistance created in the lungs because the alveoli that within the lungs are currently filled with fluid. So the resistance in the circulation in the pulmonary arteries, it's not flowing. There's resistance because fluid is meeting fluid, so it increases the resistance in both sides of the lungs. So there is, in lack of better terms, nowhere for this blood circulation to go. So this is where we end up with our next adaptation, and this is what they call the foramen ovale. Now many consider this to be a hole in the heart, if you will, but really it's not. What it is, it's a flap, and the flap opens due to the pressure gradient. So since the blood is being circulated through the heart and it's meeting all this resistance before it would go out into the lungs. It travels the path of least resistance, and so it jumps right over here into the left atrium. And that's where the bypass of oxygenation through the lungs occurs. It goes down into the left ventricle and out through aortic circulation. There also is another little adaptation right here, and this is called the ductus arteriosus. And because of the pressure gradient that we discussed within the lung right here and right here, there is another outlet for it to go directly into aortic circulation to supply all the organs with oxygen within the fetus. So this is our fourth adaptation that only infants have. These little adaptations are what create and keep the fetus alive for the 9 months that they are in utero. So it continues through aortic circulation and goes into the iliac circulation, but it also travels into our fifth and final adaptation, which are the umbilical arteries. This is the full circulation pre-birth that goes and dumps the unoxygenated blood back into the umbilical cord and back into maternal circulation. So now that we've discussed the umbilical vein and the umbilical arteries, I want you to pay close attention to this little smiley face that I have at the bottom of the diagram. So what this is this is a cross-section of the umbilical cord. So you will notice the two eyes, I made it kind of like a smiley face, the two eyes being small and round are the umbilical arteries that are bringing the unoxygenated blood that it's receiving through full circulation, dumping it back into the placenta. It is absorbed through these little finger-like projections back into maternal circulation, and thereby the mother is trading it off, so to speak, with oxygenated blood. So the little smiley face, those are the two umbilical arteries. And this long one, the reason why it is larger and more collapsed looking is because it has less resistance in order to infuse the oxygenated blood through circulation for the baby. So it kind of looks like a smiley face. Okay, so we're going to need to know what that looks like because we are going to go over umbilical venous catheterization using the umbilical cord as a site for inserting an IV line. So that's complete fetal circulation pre-delivery. So what happens just after delivery? What happens is, first of all, the umbilical cord is cut and the placenta is removed. One thing that I didn't go over is that between the one vein and the two arteries, there is a substance called Wharton's jelly. This is a gel-like material that causes cushion for the arteries and the vein to live within the umbilical cord. It also allows for the contracting and expanding of the vessels because it doesn't offer a whole lot of resistance up against those vessels. The next thing that starts to happen really quickly after the placenta is removed is that this venosus ductus, that little adaptation that sent most of the blood directly into the inferior vena cava, it starts clotting off. And of course it would make sense because there's no continuous flow, so there's not this full circulation going to and from the placenta. The umbilical vein begins, like I said, to clot off, and primary source of circulation starts to become the superior and inferior vena cava. And of course the blood starts to pull again in the right atrium, and it goes down into the right ventricle. So what happens is there's a decreasing resistance in the right ventricle because there's a decreasing resistance in the lungs. And this is because the fluid-filled alveoli are now being pushed through breathed air by the infant, and that breathing in of air is starting to push out the fluid in the lung, and the alveoli are becoming filled with air. So there is not so much resistance in the circulatory process leaving the right ventricle and entering into the pulmonary circulatory. So what now happens is the lungs are oxygenating the blood and the pulmonary circulation has started. So oxygenated blood begins to enter into the left ventricle via pulmonary circulation, and because of the resistance gradient change, this little foramen ovale begins to close. So really the best way to think about the foramen ovale is to think about it like a gate on a spring, and if you put pressure on the gate, it will open, but if you don't, it will close. So what begins to happen is, since there's equal pressure on both sides of the atrium, it starts to shut off. It closes the gate, and fetal circulation begins to look a lot like ours. So the normal blood flow out of the left ventricle into the aorta starts to take place, and the ductus arteriosus starts to constrict. Now it starts to constrict because of a few things, but one of them is once the umbilical cord down here is cut, it starts to send out prostaglandin, and it sends it due to the removal of the placenta. After fetal circulation starts, there's also sensors within this ductus arteriosus that, sensing the rise in the oxygen, it starts to clot off. It starts to deteriorate, and in and of itself removes itself. So the circulation continues as it would be with you and I into the iliac arteries and down through the umbilical arteries. Now there's a pressure resistance because the umbilical arteries, they start to clot off. They also start to constrict because of that same prostaglandin that is sent out when the placenta is removed. As the pressures rise because of the clotting off of the umbilical arteries and the constricting from the prostaglandin, over several hours, they end up not having any circulatory efforts at all. So they clot off and they go away. And that's when you have a bouncing baby. Hopefully a healthy bouncing baby girl or boy.